Good morning, y'all. First of all, my sincere congratulations and hearty thanks to the team of Pediatric Diabetes Update-2020 for this wonderful meeting and having me in. So today I'm discussing about the management of hypoglycemia and sick days in a child with type 1 diabetes. We know that hypoglycemia is a dreaded but unavoidable complication of treatment of diabetes with insulin or secretagogues in any age group, not only children. A single numerical value cannot explain or define hypoglycemia because the symptoms the onset of symptoms is different at different glucose levels for different persons depending upon their glycemic control. However, a blood glucose level of less than 70 milligram deciliter should be a clinically alert value to be proactive, preventing further reduction in hypoglycemia. A value below 54 is taken as clinically important or a serious hypoglycemic event and should be treated immediately. A severe hypo event or hypoglycemic event is described as a condition requiring external assistance for glucose administration or any other supportive measure. Now, we know that there are so many determinants of hypoglycemia in a child with diabetes. It can be precipitated by excess dose of insulin, less food intake even after normal usual dose of insulin, or after exercise. And we know that after exercise, the hypoglycemia can occur or persist about 7 to 11 hours post-exercise. So in an evening exercise, the child has got higher risk of hypoglycemia in the night. And hypoglycemia can occur in the sleep and may not be important for children, but in adolescents, alcohol ingestion can also cause rebound hypoglycemia. And these are important, and there are some risk factors like impaired hypoglycemia awareness, previous episodes of severe hypos, and longer the duration of diabetes, which will precipitate more episodes of hypoglycemia. And we know that there are so many comorbidities of type 1 diabetes, other autoimmune diseases like celiac disease, Addison disease, hypothyroidism, psychological stress leading to eating disorders can also precipitate hypoglycemia in a diabetic child. Signs and symptoms we are all well known, and it starts with autonomic symptoms of shaking, sweating, trembling, palpitation, etc. And then it progresses to neuroglycopenic symptoms like poor concentration, blurred vision, confusion, slurred speech, unsteady gait, and in severe cases, it can go on to loss of consciousness and seizures and maybe death. And in younger children, behavioral disorders and non-specific symptoms are more common, like irritability, agitation, occurrence of nightmares, especially if nocturnal hypoglycemic events occur, inconsolable cry in a very young child, then excessive hunger, headache, nausea, and excessive tiredness, then we should be alert to check for hypoglycemia. Hypoglycemia is not that simple. It is a pro-arrhythmogenic condition. Prolonged hypos can lead to brain death, and maybe it is one of the reasons for dead in bed syndrome in diabetic children. And as pediatricians, we know that hypoglycemia has several long-term neurocognitive negative effects. And this is another condition called hypoglycemia unawareness, or it's nowadays called impaired awareness to hypoglycemia. This is a condition where there is impaired counter-regulatory responses to reduction in blood glucose in a patient. This happens because of repeated episodes of hypoglycemia in a child. And the danger part is that it can lead to delayed recognition of the symptoms, and the child will land up in severe hyposymptom and risk of increased seizures. And this condition can be reversed by avoiding hypoglycemia for about 2 to 3 weeks altogether. If hypoglycemia occurs in a hospital setting, it is easy to treat with IV 10% dextrose at the rate of 2 to 3 ml per kg. But at home, the family and the parents or the caregivers has to be trained to identify hypoglycemia and give appropriate treatment. If the child is conscious and he or she is having mild to moderate hypoglycemia, a rapidly absorbed carbohydrate, preferably glucose, should be given at a day's dose of 0.3 grams per kg, followed by a slower absorbing or slower acting carbohydrate, which can be either a snacks or a routine meal if it is time for that, approximately which will provide 15 grams of carbohydrate. And retesting of the blood sugar should be done in 10 to 15 minutes. If there is no or poor response, the rapid absorbing carbohydrate has to be repeated. Now this figure shows how quickly different food substances act in case of hypoglycemia. And from this picture, it is clear that plain glucose as drink is the fastest one to increase the blood glucose level when there is a hypoglycemia, as against the counter-popular belief. Ice creams and chocolates are actually will not increase the sugar fast because they contain fat. Fat will delay the absorption of glucose. So if the child is unconscious, the most important thing is do not attempt to give oral feeds or glucose or whatever. So if possible, and the glucose powder or the tablets can be made into paste with a little water and applied to the buccal cavity in the dependent position. And another very important, very promising treatment is injection glucagon. Every family should be having this glucagon with in the emergency hypoglycemia kit, as an emergency hypoglycemia kit. And the glucagon is given at a dose of 10 to 30 micrograms per kg. So for an easy reference, we can use. This is actually available as a pre-filled in emergency kit, that is a vial containing a lyophilized powder and a pre-filled diluent, which can be just pushed into the vial and mixed and withdrawn in the same syringe. So the final concentration will be 1 milligram in the 1 ml syringe, and the dose given is in less than 25 kg children, you give half the vial, that is 0.5 milligram, and more than 25 kg or adult, you give 1 milligram, or the whole vial has to be, whole 1 ml has to be given either sub-Q or IM, and in hospital setting it can be given IV also. And glucagon prescription has to be given to every family having a young child with type 1 diabetes who is having frequent, repeated, unexpected hypoglycemic events. And this is another recent glucagon preparation, which is an intranasal glucagon spray, which is approved by the FDA in 2019. This is very easy to administer. It has a cost and efficacy level almost similar to the parenteral glucagon preparation. If there is a recurrent unexplained hypoglycemia in a child, we have to evaluate for other autoimmune diseases like celiac disease, Addison disease, and hypothyroidism. And of course, the child is having impaired awareness to hypoglycemia. Now, this is another important measure, that is mini dose glucagon. This is actually not a therapeutic regimen. This is more in terms of preventive regimen, especially in a child who is sick or having some acute gastroenteritis-like illness and with having a poor oral intake. We can give this mini dose glucagon to prevent setting of hypoglycemia. So same preparation of glucagon can be taken into a 100 IU insulin syringe, which will provide 1 unit equivalent to 10 micrograms. This can be given subcutaneously just like the insulin injections, so easily given by the parents. The dose is in less than 2 years, you give 2 units, that is 20 micrograms. From 3 to 15 years, it is 1 unit per year, maximum 15 units at a single go. And after 30 minutes, check the sugars. If it is there is no response or poor response, we can repeat using double the dose of the initial. The most important thing in hypoglycemia is to prevent occurrences of hypoglycemia. So this can be achieved by frequent glucose monitoring, adherence to the insulin regimen, adjustments of both basal and bolus regimens based on the sugar logs, and exercise-induced hypoglycemia can be counteracted by consumption of carbohydrates before and after exercise, and checking for more checking of sugars during the night, especially the exercises in the evening. And administration of mini dose glucagon can another preventive regimen. And technology, we can also adopt for technological advances like CGMS or sensor augmented pump therapy with various mechanisms to detect hypoglycemia and do corrective actions and closed loop systems. These things also will help reduce the episodes of hypoglycemia in a type 1 diabetes child. I'm going to the second scenario, that is, as pediatrician or pediatric endocrinologist, most often definitely encounter this situation where a child, type 1 diabetic, diagnosed maybe months or years ago, on insulin therapy, developing an endocrine illness, and mother and the parents are very much worried. What should we do? The child is not eating, whether we should give the insulin as usual, like that. So we know that any endocrine illness will have a negative effect on the diabetes. The blood sugars can be fluctuating between hyperglycemia and hypoglycemia. There will be more ketone production because of the relative insulin deficiency, and some infections will cause a state of insulin resistance, so that the insulin requirements will be increased, which will start manifesting from the incubation period before the symptoms manifest, and it will last for some days even after recovery of the illness. So the basic rules is that do not stop insulin completely. That this message has to be clearly conveyed to the parents, that never ever stop the insulin completely. They have to check the blood glucose and ketones. Usually we do the urine ketones, and if the patients, if it is available, or if the parents are affordable, we can advise them to have blood keto strips at home, and this can be used to monitor the ketones at least 3 to 4 hourly, maybe sometimes 1 to 2 hourly, even during the night, to detect ketosis or hypoglycemia at the earliest. And child should be advised to take plenty of oral fluids containing salt and water, not only plain water. And they should be taught to take extra doses of short-acting insulin, around 5 to 20% of the total daily dose as per the blood sugar levels and the expected carbohydrate intake. And of course, treatment of the underlying condition with the help of the pediatrician or the family physician is at most important. These are some of the general guidelines or recommendations how to adjust the insulin dose during the child with diabetic, during integral illnesses in a diabetic child. As I said, you have to check the blood glucose, if possible, blood ketones and or the urine ketones. And if the blood sugars are on the normal side, we have to take the same usual dose of bolus insulins. And if the sugars are on the higher side, depending upon the value, we have to give at least 5 to 10% of the total daily dose. Total daily dose means add all the insulin doses, including short-acting and the long-acting together, and that will give you the total dose. And 5% or 10% of the total daily dose we have to add to the usual bolus before the meals. And if the ketones are increasing, we have to give increase the corrective bolus doses. And in case that the sugars are on the lower side and the ketones are increasing, we may have to give the child extra carbohydrates or sugar containing fluids and continue to give the extra insulin doses also. This will prevent setting in of ketoacidosis. And if the child is not able to take oral fluids, he or she has to be given IV fluids containing dextrose. This will also help to prevent setting in of ketoacidosis and hypoglycemia. And some situations we may have to reduce the insulin dose during sickness. Like in this situation, see the ketones are negative, the child is having a low sugar, then we have to reduce the total daily dose of insulin 20%. And if it is below 70, the sugar is below 70 milligram per deciliter, we can try mini glucagon doses just like explained before in order to prevent hypoglycemia. And in case of increasing ketone bodies in the blood or in the increasing ketonuria in the urine, then we shouldn't reduce the insulin doses, but we have to provide more of carbohydrate or sugar containing fluids and continue to take insulin. This is a very important message. Now, in a child who is on insulin pump therapy, first and foremost thing is to check the functioning of the pump, whether it is delivering appropriately, correctly, the insulin doses. If there is any block in the mechanisms of the tubings or there is an infection in the site where the pump, the cannula is attached. So if that is okay, then we can give the correct doses through the pump. Otherwise, if it is in doubt and if child is having blood ketones, then we have to keep the correction boluses through syringe or pen till the pump mechanism, the pump is serviced back to normal. And there are situations when the child needs to be referred to a hospital setting, like when the child is having persistent fever and underlying illness is, or what is underlying illness is not clear. When the child is having persistent weight loss, which indicates continuing dehydration. If the vomiting is persisting more than 2 hours, the blood glucose is falling below 70 even after giving oral carbohydrates, or the child is not able to take oral carbohydrates, persistent hyperglycemia, worsening of ketosis manifesting as blood ketones more than 1.5 millimoles per liter or 40 order in the breath, developing of abdominal pain, hyperventilation or alteration in sensorium, and other comorbid conditions like some primary neurological illnesses, Down syndrome, etc., which will make diabetes management more difficult. In these situations, child has to be referred. And if the parents feel that it is difficult for them to manage child at home, they should be referred to an emergency care setting. And that is my last slide. Thank you for patient listening, and thank you once again for the organizers.